This recording will go over Chapter 39, Pain Management for Children. Assessing and treating pain in children is a vital part of nursing care of children, although at times it can be difficult. Infant and children are often unable to communicate the presence, location, type, or intensity of pain. Parents may be hesitant to allow suitable pain management because of fears related to side effects from the use of opioids, including inaccurate fears regarding addiction. Additionally, nurses and other healthcare providers continue to have misconceptions about opioid pharmacokinetics and unwarranted concern about the adverse effect of opioids use in children and infants. Despite the increasing knowledge regarding safe and effective pain management in children, as well as widespread anecdotal experience, children remain at risk for unrecognized and undertreated pain. Consistent, appropriate use of pediatric pain assessment tools is not always seen among pediatric nurses, and many nurses feel that they are not knowledgeable enough about pain assessment tools to use them accurately. We're going to skip forward to obstacles to pain management. The two beliefs of parents and nurses that are most likely to interfere with the provision of adequate pain relief in infants and children are fear of respiratory depression and fear of addiction. In addition, many nurses believe that children over-report their pain. Table 39.1 lists and refutes other prevalent myths about pain and pain management in children. Please review Table 39.1, which goes over myths about pain management in children on your own. Pain in children is multidimensional and subjective. It is affected by the type and duration of pain, developmental level, emotional status, previous pain experiences, culture and ethnicity, personality type, gender, genetic variations, and parental response to the child's pain. These factors should all be taken into consideration when assessing an infant or a child in pain. Consequently, assessing pain in infants and children is more challenging than in adults. The nurse's role is to assess for pain, provide non-pharmacologic and pharmacologic interventions, along with the healthcare team, and evaluate the effectiveness of these interventions. Infants and young children may not have the language or cognitive abilities to communicate their pain. Their cry and verbal responses occur for many reasons, including hunger, sleepiness, and anxiety. Accordingly, the nurse must use a combination of behavioral and physiologic signs together with an appropriate pain assessment tool to determine the pain level in infants and some children. Vital signs data such as heart rate, blood pressure, respiratory rate, and oxygen saturation have been reported to provide information about acute pain. However, these physiologic signs are also affected by other factors such as illness, fever, and medication, and there is little evidence to support using changes in vital signs to assess pain. Behavioral and some physiologic signs can play an important role in the assessment of pain in children who are given a verbal report of pain that differs from their nonverbal behaviors. Although older children may be able to verbalize their discomfort, they are often afraid of treatment that includes a painful procedure such as an injection. They may also have been told to be brave and not verbalize or demonstrate the pain they are experiencing. Please review box 39.2, Indicators of Pain According to Developmental Levels, on your own. Consistent, appropriate use of a pain assessment tool is essential to pediatric pain management. A number of valid and reliable pain assessment tools are available to help the nurse make a more accurate pain assessment. An assessment tool should be used that corresponds to the child's developmental abilities. The crucial factors considering selection of a pain assessment tool are that it is appropriate for the child's developmental level and can facilitate the development of an effective pain management plan based on information gathered from the assessment. So if you look at page or table 39.2 that has a list of the different pain assessment tools, I want you to be familiar with FLACC, F-L-A-C-C, the FACES rating tool, and the numeric rating scale. So we'll start with the numeric rating scale. That's what you're usually used to with your adult patients, where they give a rating between 0 and 10, 0 being no pain, 10 being severe pain. The FACES scale you can see here on your slides, also in your book, where the child would point to a face that they relate or they regard shows the amount of pain that they're experiencing. So they pick a face that shows how bad it's hurting, and then the nurse is able to monitor pain, medicate, and evaluate whether the medication was effective based on using the face's pain rating scale. And then finally, the FLAC, Face, Legs, Activity, Cry, Consolability Scale. That scale can be used for infants and pre-verbal or non-verbal children. And it basically assesses what's going on with the face, the legs. Are they grimacing? Are they flailing their legs? Here, I pulled up a FLAC chart. So face, no expression or smile, they'd get a 0. Quivering chin, clenched jaw, frequent to constant frown, they get a 2. An occasional grimace or frown, withdrawn disinterest, they get a 1. And the legs, normal position, relaxed, 0. Uneasy, restless, tense, a 1. Kicking or legs drawn up, a 2. So I'm not worried about you memorizing what's happening in each of these 3 categories. I want you to know what they're measuring: face, legs, activity, cry, consolability. I want you to recognize that a 0, just like with the numeric scale, would be a good thing, right? Would indicate less pain, no pain, and that a higher number would indicate more pain. Please review the non-pharmacological interventions on table 39.3 on your own. These should be review for you. In regards to pain management for children, the preferred routes are IV or oral. As soon as a child can take oral intake, the route should be changed to oral. Infants and children receiving IV and epidural opioids should be monitored by pulse oximetry, so they probably have some continuous pulse ox monitoring going on. If respiratory depression occurs with opioid use, naloxone, hydrochloride, or Narcan should be used for the reversal when oxygen and stimulation of the child are ineffective. And here's your practice question. You can go ahead and pause, read through, and get your answer. The correct answer for the practice question is B as in boy.